So the reason I was talking about pharmacology is I got a question or two before the last test, and I wasn't quite sure how to answer them, and then I mull things over and think of something later, and I say, well, I wish I'd said this, I wish I'd said that. Because people said there's so many side effects and there's so many nursing implications sometimes that I don't know what is important, what patient family teaching is important. And then I thought about the things that are in italics and things that are underlined, and it tells you at the front of your drug book, and it occurred to me that some of you might not have ever realized that kind of clues you in a little bit. If there's just tons of side effects, and we know from acetaminophen and aspirin and things, there are tons of possibilities. But that might help you narrow it down. And it's actually in the front of your Pearson Nurse's drug guide, whether something's italicized or something's bold or something's underlined, gives you a little more information. And I think you all have been told about black box warnings, but we might go over that again. So what I would like for you to do now, we're going to divide your classes into 3 groups. One group will develop information on the class of drugs, protease inhibitors, and your prototype will be nalfenavir. And that's another thing it tells you in your drug guide. When you go to nalfenavir, it tells you how to pronounce it. Sometimes I can read that and I still can't pronounce it, but sometimes I can. So a third of you are going to do a drug card, I guess, on nalfenavir. A third of you are going to do a tenofovir, and then
Mrs. Martinez,
yes,
would you write these on a piece of paper and just put them on the document camera so they know how those are spelled?
sure. I can even tell them too where they are in their drug guides.
Oh, okay, whatever works better for you.
Okay, rilpivirine is on page 1436. It is a non-nucleoside reverse transcriptionase inhibitor, which is abbreviated NNRTI. Let me find, I've got my guide. Tenofovir is on page 1568. And the last one, real tenofovir is a NRTI, protease inhibitor, and then let me find my other one. It's actually, there's a chart in your book too, on page 352, of the different drugs, and the third one is going to be yeah, rilpivirine. It is RILPIVIRINE. And it's an NNRTI, and I'll see what page it is.
That's on that 1436,
That's
right?
1436, yeah. So, what, do you all 3 pages?
No, you have 1436.
Okay.
What's the first one, please?
Can we do all three, or? A third of you, you're gonna divide up, and I guess we can pick.
What was this, number 1538?
I'm looking up
Do you need it?
the phone number for.
Are you still using it? I mean, we all have
I
to use
know,
it, so it's
that-
fine.
that's not what I'm hoping. Get back here, we're gonna do it.
I'll just move with you. To know for you is. I'm not with you guys. Okay. Great.
What do you want on our drugs bags, Ms. Martinez?
I want you to put, how does this work? Ruth that did, you're giggling, aren't you? This is an easy question. Tenofovir, on page 1568. You're all going, not us, I'll bet, we're not. Is there,
They're giggling because there was some confusion when it comes to fruits. And so the student I'm about to rat on is telling me they fixed the problem. Anyways, that's all they're laughing about, is because they're afraid that their drug was gonna be requested, and
sure enough it was.
it was.
Is there a black box warning?
Yes.
Okay, so you guys know that anytime there's a black box warning, you would, any of your clinical instructors would expect to see something about that on the drug card, I think. Let's see, do you feel like, the instructions that you would give patient family teaching would be difficult?
No.
No, it's simple, isn't it? And it's pretty consistent with nearly all of these drugs. So we're gonna get back on target, and I just did that to make it easier for you the rest of the semester, really, to, maybe to do your drug cards. I don't know that I gave my clinical group much instruction on that, so. I thought maybe some other teachers might not have either. So, home care, collaborative care, when someone goes home, and this is in the chapter 2, there's a chart that talks about, it's on page 351, teaching you what to do with your clients. And some of it, like not to eat raw veggies or fruit, those are things we generally encourage people to do. But because there can, even though you wash them really good, like an orange peel with those little dots, it's hard, even though you peel it, you don't eat the orange peel. Well, sometimes you do, sometimes you shave it into a recipe. It's hard to get that completely clean. So it is, maybe grapes as you pull them off the stem, right where you roll them off the stem, that's a place where there could be some sort of fungus right at the edge. So we just encourage people not to eat the raw fruits and veggies, and then, it says in that chart, even to clean your toothbrush, maybe, is that with bleach once a week. I've never thought of telling anyone to do that. It is really, I know you can read that pretty much for yourself. There was something about women of color in particular seem to do poorly and live shorter lives with HIV and probably transmit the disease to others. So somehow we're missing women, minority women, either in our education of how to take care of themselves or how to take their medications. So we're, as a society, we're not doing a great job with minorities in general, but women, and that's Latino and Black primarily, but with women even more so. So more women of color are getting diagnosed and living shorter lives than anyone else. So I
So
think
is that slide something like not as used, like, the way it's worded?
Like, what do you mean by that?
It's like, this is not as used much with HIV plus women of color.
Oh, okay. There's a, like a computer-based program. I don't remember what it's called. It's a software program that reminds people about taking their medications. It has them record their temperature.
Oh, so
and
not is
all-
the
but
website.
For some reason, we're missing the boat a little bit with women of color and our minorities because some people get access to this and they get really good at self-monitoring and self-care and taking their meds correctly and not missing any. There's a 90% rule that we're gonna have to hit, you're absolutely gonna have to know. About how important it is, but somehow the transmission of knowledge and teaching and getting it across isn't working as well. There's an article in your book about that. Okay, so when we're doing our teaching, we need to be, of course, non-judgmental and show consideration and concern for our clients. If there's some stigma related to this illness, people sometimes automatically expect you to not be very nice to them or not to care about them or to not want to take care of them. That was the way it was in the beginning. I think it maybe it's gotten a little better over the years, but there's still healthcare workers who say, oh, I don't want that assignment. You know, I don't want to take care of that person in that room, you know, and people are very good at picking up on things like that. A lot of people who are HIV positive do need some counseling. There's a lot of anxiety and depression and lots of social isolation. So, okay. So when you do your assessment, it's a big assessment. You're looking at, you know, and some people we tend to skip over their sexual history and their practices and if they've had sexually transmitted infections. If they come in with heart failure, maybe. But with this population, you can't skip over that. You do have to ask them if they are IV drug users, even if there's no indication or if they ever have been. So you really have to get a good history and you just can't really skip over any information. And then asking them about infections they've had in the past, if they've ever had any malignancies. So it's there, on page 346, but it takes a thorough assessment. Everybody should get a thorough assessment, but these in particular, there's just nothing you can really overlook. Now, I added just a little bit, I said put in red some of these, in fact, the opportunistic infections or AIDS-defining infections. Again, straight out of your book, I just put the people I've taken care of with some of these. Sometimes a yeast infection, recurrent yeast infections in women is how they end up getting diagnosed. So that seems like a pretty benign thing, but if they're constantly having them, it can mean that their immune system is depressed, and with further lab work they can determine if it's HIV. As I said, this is straight out of your book. You don't have to know all of these words, but you need to know that it can be fungal infections. It can be bacterial, it can be viral, protozoan, any kind of infections you're susceptible to. And a lot of different pneumonias, unusual pneumonias, that when they try to culture, it takes a while sometimes to figure out what they're dealing with. The Kaposi sarcoma, I think maybe that's Kaposi's, I'm not sure how that's pronounced even, is disfiguring and embarrassing to people, so they tend to isolate and stay home a lot. The lymphomas that are primary brain infections, that's a little unusual to have something that's the first place you find it. There is AIDS-related dementia, and it has to do with infections as well. I don't think it was hit on really in your book, so I'm not in any detail, so I'm not going to either. So, complications of these drugs, the combination antiretroviral treatments. There are a lot of them that cause people to not want to take their medications. The gonadal dysfunction with low testosterone, low energy. You know, women have a little bit of testosterone too, so this affects men more, but it also affects women. The protease inhibitors and the NRTI sometimes cause lipodystrophy, which the people will get fat, like a hump, buffalo hump kind in the back sometimes. They'll lose muscle mass and get, people who really have never been fat before will get some abnormal distributions of fat that is disfiguring and embarrassing to them if they've always taken pride in their appearance. They know they're eating the same, they're not doing anything different, and they know it's a side effect of the medications. It's a temptation not to take those medications. Sometimes they have adrenal insufficiencies. The protease inhibitors make you a lot more likely to develop diabetes. Also to have increased triglycerides and cholesterol. Isn't that strange? We think that's food related, or maybe our genetics, but a medication can cause that as well. So they're higher risk for diseases associated with those. There was something on this slide, I can't remember what it was, did it say hand or something like that? Yeah. I couldn't figure out what that was. I Googled it, I looked in the book, I decided that
It's on 348.
It's on 348, you found it? Okay. So tell me what it is since you found it.
HIV-associated neurocognitive disorder.
Oh, so it's the dementia type thing. Okay. So I talked about the buffalo hump on the back. It can also be right at the back of the neck, which is not a pretty place to have a lump of fat. So, yep, there it is by going. I looked and looked for that. Okay. So the AIDS-defining conditions, and like I said, there is some dementia, and it can be pretty severe, and in fairly young people, of course. So hemophiliacs were some of the first people who were hit with AIDS before the blood got screened. So that was a lot of times teenagers, and to get a dementia related to that is probably pretty tough. There's neuropathy and myopathies, which are pain with your nerves and muscles. A lot of times gabapentin is prescribed for that. I think you're fairly familiar with that medication. The wasting, I added a couple of slides because this is something that nurses can help with. The goal is to make small weight gains, and sometimes that means they need to nibble through the day and eat frequent small meals, 5 or 6 a day, sometimes with protein shakes. I know most of you have had a patient in the hospital or ran across from one that they were trying to get built up nutritionally. So it was much the same. They'd get a snack in the afternoon, and it usually had something high calorie or high protein. However, some of the things that the antiretroviral medications cause people to not be able to tolerate fatty foods a lot of the time. So the AIDS-associated wasting, you'll see weight loss, people will complain of decreased energy and a loss of muscle. It can be from their high metabolic demands of fighting infections. I imagine some of you have had weight loss from the time you've been sick, just because your body was so stressed and was working so hard. Diarrhea, it can be commonly associated with infections, GI tract infections, or it can be a common side effect of a lot of your antiretroviral meds. Sometimes, and this can be a side effect of food, or it can be from oral infections. Food just doesn't taste good. There's a lack of appetite. So, if you had thrush or candied in your mouth, you probably wouldn't feel like eating. And we tend to think about that with maybe people who've been on a lot of antibiotics, or but it is associated with HIV as well. There's maybe one more. So, some of the things that might be done is adding supplements. If they're anemic, of course, you're going to do some iron supplements. Avoiding a high-fat diet, because that may make the diarrhea worse if they're having diarrhea. The small frequent meals, medications to combat diarrhea, of course, if it's there. Some of the mouth care, sometimes there are anesthetic gels that people can use to decrease the discomfort in their mouth so that they can eat. People may be on calorie counts, they may have to have 2 feedings. I should have capitalized TPN, total parenteral nutrition, is sometimes required. That's the nutrition through the vein that you've probably seen last semester. So evaluation, small weight gains or victories. You can have reductions in diarrhea, but it might be good one day and bad the next. So it's really hard to use that as an evaluation if it's, you might see someone in the morning and they're like, oh, I think it's gone, and by late afternoon, it's back with a vengeance. So that's kind of hard to measure. Being able to wean people off 2 feedings or TPN because they're eating better is always a happy time. In lab test, you're going to look at albumin levels and total protein levels. Maybe their hemoglobin and hematocrit as well. And then it's subjective, but energy level, as reported by their client, if they have enough energy to resume some of their normal activities, that's going to be something you're going to want to see or hear about. Just pausing for a minute, because I know when we add a slide once in a while to give you more information, it stresses you a little bit to have to add things in. Okay, so your psychosocial assessment, finding out who this person's support system is, if they have a healthcare proxy, which is really, someone who's able to make decisions for them that they've identified in writing, if they're not able to do it themselves. If they're able to do their own ADLs or they need help, are they still able to work? A lot of people who are HIV positive can maintain their employment. Healthcare workers can maintain their employment. Sometimes there are some adjustments that have to be made. I'm not sure why immigration status is on here, except if it has to do with eligibility for some of the programs that the pharmaceutical companies have. It shouldn't, it's possible, I guess. What they like to do socially that they can still do and maintain some social relationships. You have a secure place to live. What are the financial resources and do they have the energy to do the things that they probably need to do? Insurance, I think in most states, if you're HIV positive, there's a medication program that you can get on that will pay for your antiretroviral meds. I know there is another one, and we're not very progressive, so. Drug and alcohol use, that's important to know because it affects, how well people follow the medication regimes. And then if they're having trouble with anxiety or isolation, they're struggling with finances and having a hard time admitting it, but that maybe they can't afford their food or different things, and how they're dealing with maybe their family, telling people that they're HIV positive, so all those kinds of things. So we talked already about the lymphocyte count, and in your lab book, it's slightly different. These little slight differences from one book to the other aren't going to hang you up too much. It says, I think, 15 to 45, maybe. No, 20 to 40 for the percent, and in our textbook, it's 30 to 40. So, if there is a test question, which I don't recall, it would be 30 to 40, we would go with our textbook. The absolute cell count, I think, was around, what was it, 800 to 4,500, something like that? No, 15 to 4,500. We'll stay with that, like it is on the slide there. Your normal CD4 count is 600 to 1,200. In the United States, we start medication usually as soon as someone's HIV positive around 500. I think it said in the book in Europe, they wait till the count drops to around 300. What were the ranges? The CD4 cell count, normal is 600 to 1,200.
What was the very first one that said like 40 to?
30 to 40, that was your lymphocytes percent of your white blood cells.
Okay.
And if you look in your lab book, Pagana, or that's what I call it, but some people call it Mosby's. It's on page 467. It talks about your white blood count, and that's important to know. The normals, I think what we call normal in our textbook, I think is 5,000 to 10,000. And that's what it says in here too. And it says critical is different, so you should know the normal at least of your white blood count. And that's that consists of neutrophils, lymphocytes, monocytes, the whole thing. So the testing, a lot of times it's two-part test. It's this 4th generation HIV assay combined with viral load. The old test, the ELISA and Western blot are slow and take longer to get to know. So you could draw the blood and think somewhat, it would take them maybe 3 weeks to convert with an ELISA. So that's not really, I don't think, used very much anymore. Okay, so we've covered really this slide, except over on the right side, taking it exactly as it prescribed. You're gonna take it for the rest of your life. Take it every day, as close to the same time as possible. And the 90% rule is that they have to take, 90% of the time has to be taken correctly, the right dose, the right time, with food, just exactly as it's ordered. So if you're supposed to take 1 pill a day every day, and let's see, it's April, so there's 30 days this month, following the 90% rule, how many pills can you miss without risking this virus, this evil genius virus, becoming resistant?
3,
Okay.
but not in a row.
3 would be the maximum. 3 days out of 30 that you could be off. Maybe you forgot to take your 8 o'clock dose or your 9 o'clock dose that you take every day until noon. Or so your blood levels might get off. Or you skipped a dose. It's pretty easy for this virus to become resistant, and once it's resistant to drugs, it's resistant. And what's really kind of interesting is, I hope I'm trying to say this, that, depending on who you got your HIV from, if they had taken, nalfinavir and not taken, followed the 90% rule, and there was, it's not gonna work for you, because your virus is already resistant. Okay, so interventions, just some things that you do to help people. Most people, if they're hospitalized, have some sort of respiratory infection, need some respiratory support. They're mostly nutritional therapy, they need help with their oral care, all of these things. So, and you can go back to those charts, it says no cat litter handling. They really should not have reptiles as pets because they have a lot of funguses, I guess. I'm not sure really what reptiles carry, but give away your turtle or your snake if you HIV positive.
I'm sorry.
I mean, my daughter does, but iguanas, no iguanas, no bearded dragons, none of that stuff. Okay? And then in your evaluation, you'll find out if they're following their 90% rule. I know we're running out of time here. Do they know how to prevent transmission to others? Are they taking care of themselves? And then psychosocial, a mental status assessment. Do they have friends? Do they socialize? And that's the end of my slideshow. And it says, like your capture workstation